Hello and welcome to the 7th annual AAKP Global Summit on Kidney Disease Innovations, themed The Decade of the Kidney at Midpoint: Opportunities, Barriers to Greater Innovation, and Freedom from Disease and Disability. This annual event is proudly hosted by the American Association of Kidney Patients in collaboration with our allied partners at the George Washington University School of Medicine and Health Sciences. My name is Dhawan and I'm honored to serve as an AAKP International Ambassador from India. I'm also a CKD stage 5 patient on dialysis and I'm awaiting a kidney transplant. Professionally, I'm an independent filmmaker and these days I've been focusing on writing. I just recently completed my latest book. 3 years ago, while working on one of my film projects, I was unexpectedly diagnosed with kidney failure. Unfortunately, none of my family members were a match for donation. So currently, I'm awaiting for a cadaver kidney transplant. Being involved in AAKP allows me to be more confident and more comfortable with my diagnosis of kidney disease, and provided me with a platform to spread awareness about kidney disease and emerging research such as bioartificial advancements in transplantation. Since 2019, the Global Summit has served the global kidney community as the largest patient-led kidney disease innovation summit in the world. This year's Global Summit marks a critical milestone for the global kidney community because it's the midpoint of the AAKP-led decade of the kidney. This global initiative has been mirrored across worlds by the kidney advocates, medical allies, government officials, and among people of goodwill committed to return of true patient-centered medicine. Throughout the first half of the decade of the kidney, we have raised awareness about the increasing burdens of kidney disease worldwide among people, communities, workforces, and governments. This effort also accelerated and determination to transcend status quo treatments, including brick and mortar dialysis, to a future of kidney care that will be determined by expansions in patient consumer care choice, targeted therapies that stop kidney disease and prevent kidney failure, greater access to donated organs, new devices, and alternatives to human organs, including artificial wearable and implantable kidneys and xenotransplantation. We believe the time is now as we move through the next 5 years of golden age of kidney medicine, where much progress has already been made for patients, care partners, clinicians, researchers, innovators, industry, and government leaders to accelerate our bold actions and push forward modern diagnosis. Also, devices, therapeutics, and continue to move outdated policies that block their adoption. No country is immune to the impact of kidney disease. But the good news is every person watching has a role in shaping a future for all people who are at risk for or living with kidney disease that can offer more hope, better outcomes, and greater independence and freedom from disease and disability. Now, with that, I'm honored to serve as the moderator for our session entitled Alternatives to Human Organs, Artificial Implantable, Artificial Wearable, and 3D Printed Kidneys. We're kicking things off with two of the longtime friends and allies of AAKP, that's Dr. Shuvo Roy and Dr. William Fissell. Dr. Roy is a bioengineer at the University of California, San Francisco, and technical director of the Kidney Project, a national effort to develop the first ever surgically implantable artificial kidney. Joining him is Dr. William Fissell, a nephrologist and researcher at the Vanderbilt University Medical Center and medical director of the Kidney Project. These two innovators are helping us to turn bold ideas into real solutions for patients. Please join me in welcoming Dr. Shuvo Roy and Dr. William Fissell.
Thank you. It's a pleasure to be here again with the AAKP community and with George Washington University. I am Shuvo Roy, Technical Director of the Kidney Project and Professor of Bioengineering at University of California, San Francisco. I've been working with the Kidney Project for well over a decade with my colleague, Dr. Fissell.
Hi, I'm Bill Fissell. I'm a kidney doctor and a biomedical engineer at Vanderbilt University Medical Center in Nashville, Tennessee. Shuvo's being modest. He's spearheaded the Kidney Project for 2 decades now, right alongside me. I want to underline our thanks to AAKP and to George Washington University for hosting us and letting us up on our Shuvo.
Yes, so at this juncture, I thought we would provide an update, an overview of the kidney project for those of you who are already familiar and for those of you who may not have kept up to date. So the best way we thought of doing this is to share a video that summarizes the past work and takes us to the current status. Let's play that video.
People living with kidney failure can soon look forward to a future without dialysis or an endless wait for a transplant organ. Combining continuous treatment with total mobility, the implantable bioartificial kidney will give patients back their health, freedom, and quality of life. The compact device will replicate many functions of healthy kidneys and will not require immunosuppression drugs. The bioartificial kidney combines a mechanical hemofilter to remove toxins from blood and a bioreactor containing engineered renal tubule cells to maintain water volume, electrolyte balance, and metabolic functions. Highly efficient membranes, constructed from semiconductor silicon wafers, enable filtration without requiring pumps or electrical power, while protecting the renal cells from rejection by the patient's immune system. The biocompatible device attaches to the circulatory system and removes toxins to the bladder as waste. After a decade of engineering development to refine the hemofilter and bioreactor components, preclinical prototypes of the implantable bioartificial kidney have been successfully created. Cleanroom microfabrication processes have been established to reliably produce high-quality silicon membranes. Tissue culture protocols have also been optimized to reproducibly grow renal tubule cells and maintain their function. The silicon membranes were mounted in polycarbonate housing to construct hemofilters, and in similar fashion, bioreactors were assembled to immunoprotect the renal tubule cells. The hemofilter and bioreactor components were then connected to create bioartificial kidney prototypes for benchtop and preclinical testing. Devices were surgically implanted in animals and connected to their renal blood vessels and bladders. In proof-of-concept experiments, the hemofilter operated under the animal's blood pressure alone, without systemic anticoagulation, while the renal cells in the bioreactor remained alive and healthy without immunosuppression. The animals suffered no blood clots, loss of albumin, or other adverse effects. Further improvements will scale up the prototypes with additional silicon membranes and renal cells, creating clinical devices that can demonstrate sustained treatment of kidney failure in human trials. The implantable bioartificial kidney will provide the therapy and mobility patients need to move beyond the burdens of dialysis and organ shortage, and once again enjoy the freedoms of everyday life.
I hope you understood where we have come to and where we had initially started. We started off with a concept that Dr. Fissell outlined for me well over 2 decades ago, and today we've got functional prototypes that are producing urine. It uses a semiconductor technology as well as kidney cells that are incorporated into the device, and it provides those key functions of a kidney. And today we've got working prototypes that produce urine in preclinical models of kidney function, as in this particular case, a pig. I'll let Dr. Fissell talk a little bit about the features and the benefits of our approach. Bill?
Thanks, Shuvo. I want to outline some of the fundamental differences between our approach and the conventional dialysis treatments that most Americans with kidney failure have to accept. Our approach works around the clock, just like a real kidney. It spares patients from this roller coaster of fluid overload followed by a quick session of dialysis that drains the patient of salt water and drains the patient of energy, and in many patients actually stresses their hearts. The second feature, again, working around the clock, constantly, provides enough removal of minerals and wastes that patients will be able to eat a more normal diet. Patients do not like having to go to a restaurant, for example, and have a special meal for them. It stigmatizes them. It makes them stand out. Why can't they have the food that they want to have? Why can't they have the food that they enjoy? Our approach lets us do that. Let's also contrast this with some of the other technologies that we've heard about in the news lately. We've heard a lot about other sources of kidneys for patients in need of a transplant. The imbalance is huge. We know this. Over 500,000 patients with kidney failure in the United States, 100,000 patients waiting for a kidney, and only 20,000 or so transplants a year. The need is immense. Xenotransplantation, the use of a kidney from an animal to be placed in a person, has been an exciting idea ever since it was first conceived decades ago. The challenge here, and it's exciting that these have finally reached human patients, absolutely, but the challenge here is the dose of immune suppression that's been required in these patients to allow them to accept an animal kidney into a human body. I desperately hope that more progress is made here because this is exciting. I just worry that we keep pushing tomorrow further and further and further in front of us. We know that patients really don't like dialysis. They don't like sitting on the machine. They don't like coming to the dialysis clinic. And they certainly don't like the way that the dialysis process, with gallons and gallons of dialysate and tubing, catheters and needles, straps them to some clinic, some place, or for the lucky few, in their own homes, but still is a fundamental barrier to being able to live their best lives, to being able to travel, to be able to visit friends and visit family without having to make elaborate plans long in advance to be a guest at a faraway dialysis unit or have their supplies shipped somewhere and hope that they show up on time. Our approach, no pumps, no lines, no catheters, nothing breaking the skin, no sources of infection like the catheter infections that plague patients who depend on catheters for dialysis, fundamentally lets people move around. Again, our goal is that we let patients lead their best lives using appropriate technology, silicon micromachining, living kidney cells, human kidney cells. We can clean patients' blood, regulate their fluid volume so that they can go about their lives the way they want to. That's the advantage that we have. And we have real devices that function today on a small scale that we've been able to implant in experimental animals that filter the blood, process that filtrate with tubule cells, and concentrate those wastes into a little stream of yellow fluid called urine. Shuvo?
So, what you've heard and seen is the status of our project and the features we bring to the table. To reiterate, we have functional working prototypes, but as Dr. Fissell just said, they are small scale. So what do we need to do next? We need to scale up. Scale up meaning provide enough capacity to treat humans. And therein lies the next stage of our journey. We have to scale up the amount of filter material we have in our device, scale up the amount of cells we have inside our device, and then also scale up the time period to show that we are actually going to be able to provide an improved quality of life. So this work is fundamentally an engineering effort, not relying on fundamental new discoveries. We've already shown this can be done. So now we need to engineer more membranes and more cells and show the device works to provide therapy over a longer period of time. And that will be our journey looking forward. We're excited about what we have achieved. We're excited by the possibilities ahead. Thank you.
Thank you, Dr. Roy and Dr. Fissell, for your excellent presentation. Before we move to our next speaker, I'd like to ask a few questions to you. The first question is for Dr. Shuvo Roy. For our international audience, can you tell how much progress has been made since your first appearance at the Global Summit 5 years ago? And what's your assessment of where we stand now on an important work in artificial organs, especially as we reach the midpoint of the decade of the kidney?
It's a terrific question. I should say, the field saw a gap. The gap was COVID and the challenges it brought forward. So the progress not just affected us, but affected the whole field and many fields altogether. And that did slow us down from our original intended pace of work, also delayed some of the tasks that had to be done. But as I look back, the field of artificial organs has really become invigorated, not just our group. There are groups in the country, there are groups across the world that are now focusing on bringing technology for artificial kidneys. And I like to think that the work we did and the collaborations we've put together with technology and scientific folks and patient groups like AAKP have brought us to this midpoint of the decade of the kidney, where today we're now looking to embark on the next stage, which is not answering fundamental scientific questions, but to reiterate what Dr. Fissell said, scale up and engineering to make this suitable for the first clinical studies. We know the technology that is needed. We understand the science that's available. We're going to put them together, and right now, at the midpoint of the decade of the kidney, I think we're very well positioned for the next step. And the field of artificial organs, especially in kidney therapy, is coming together using exciting technologies like the xenotransplant to people making portable dialysis. And then our approach that tries to say, let's get to something that will provide the patients the benefits of a transplant without having to deal with all the challenges, but also provide the quality of life that they deserve.
Second question, looking ahead, what do you anticipate over the next 5 years? How can patients, researchers, and medical professionals watching this effort today help you bring this to clinical trials in the next 5 years?
This work is a collaboration between different disciplines. There is the scientific and engineering disciplines that merge with the clinical disciplines. But also we bring in patients, we bring in the business community to also add the support community that's outside of this to help move us forward. And I think what we all have to do together is to realize that this work that we're doing is not waiting on some fundamental scientific discovery, but let's collaborate to make this a reality and scale up. So to do that, we want all our stakeholders in the different fields that they're in, one, to have hope, two, to focus on the goal that this can be done within the space of the next 5 years to get to the first clinical studies, because the science is there and the technology roadmap is available. And together deliver on getting this innovation to the first clinical studies and beyond. So it will require all of us to work together, support each other, attract resources, attract collaborators, and work together with a goal that's patient-centered. And folks across the world and members of AAKP, as well as other patients and their family members, should have hope that the implantable bioartificial kidney and the kidney project is committed to what we are doing for the device, but also committed to what the benefits will be for them.
Dr. Fissell, How is your team engaging with patients, clinicians, and regulators to ensure these technologies are not only innovative but also safe, affordable, and accessible once they reach the market?
What a terrific question. That's been our goal from the get-go, is to have a safe, effective device that's available for everybody. And I want to make sure that we underline our gratitude to AAKP for the continuous contact that AAKP has had with our project for decades, where we've been able to sample the opinions of patients with renal failure, the opinions of patients who have had a transplant, the opinions of patients who have had to depend on dialysis, to make sure that where we're headed is a place that patients want us to go. And AAKP has been foundational in our ability to keep checking back and make sure that we're on the right track. I'd like to emphasize how helpful the Food and Drug Administration has been to us in the past. Participating in the Innovations Pathways program, working very closely with regulatory officials at the Centers for Devices and Radiologic Health has helped us shorten our timelines for development by understanding the areas of regulatory emphasis where the FDA sees the pressure points, sees the advantages, and sees the risks of a device like ours. So we've been walking hand in hand with the FDA for the better part of 15 years to make sure that when we achieve a large-scale clinical device that can provide enough kidney that patients don't ever have to go back on dialysis, that will be ready to go from a regulatory standpoint as well as from an engineering standpoint. Finally, the Food and Drug Administration actually introduced us to officials from the Center for Medicare and Medicaid Services. As you may know, the federal government has an end-stage kidney disease program that underwrites the cost of dialysis for Americans with kidney failure. And we've been working with them to make sure that when the day comes, we can have a product that fits into their scheme, their plans for how they reimburse providers for the cost of a kidney transplant, for the cost of home dialysis, for the cost of in-center dialysis. So we've been very fortunate that the federal government has recognized the urgency for new treatments for patients with kidney failure, and we've been able to have some degree of reassurance as we move along, not just that we've got a firm scientific and engineering basis, not just that we're meeting and recognizing and addressing the unmet needs of patients with kidney failure, but also, as we make progress, we'll be able to deliver a product not just to the lucky few, like happens with kidney transplant, but to every single patient who has kidney failure who wants to check out, test, observe, and try an alternative to dialysis.
Lastly, what do you see as the most exciting scientific or technological breakthrough on the horizon that could accelerate the development of a fully functional bioartificial kidney?
I want to emphasize something that Dr. Roy mentioned earlier. We've made the fundamental enabling discoveries. Dr. Roy, with his semiconductor wizardry, has invented the first new membrane for blood separations in 40 years. Our group, along with Matt Wilson at Vanderbilt and others, have developed protocols where kidney cells differentiate, grow, function, and concentrate toxins in a laboratory dish. We've had technologies that let us eliminate the need for blood thinners, the heparin, the warfarin. We've got an architecture that eliminates the need for immunosuppressive drugs. So patients who've had problems with infections, patients who are recovering from a cancer can still receive this kind of therapy, the benefits of a kidney transplant. I want to emphasize that the fundamental discoveries have been made. What we need to do now is scale up what we've built, get it on a clinical scale where we're able to give patients enough function to be healthy, and develop the knowledge base of how the device can be most safely and effectively used in the 500,000 Americans who suffer from kidney failure. The most exciting developments for us are going to be resources to bring this forward, not some curiosity-based discovery science. Yes, absolutely, there are going to be technologies that help us. There's CRISPR gene editing technology. There's next generation 3D printing technologies. There's robotic assembly. There's AI guided scientific discovery. All of these things are going to accelerate what we do. But I want to underline, the discoveries are done. It's development, scale up, engineering, and delivery of these technologies to the patients in need that's going to excite me.
Thank you, Dr. Roy and Dr. Fissell. What we have heard today gives real hope to patients and families in that innovation is not only happening, but is moving closer to treatments that offer greater freedom, fewer burdens, and better outcomes. Now, it gives me great pleasure to welcome our next speaker, Dr. Buddy Ratner, a true innovator and a long-time leader in the effort to improve kidney care through technology. Dr. Ratner is co-director of Center for Dialysis Innovation at the University of Washington, where he also holds the Michael L. and Myrna Dahlen Endowed Chair in Technology, Commercialization, and serves as the Professor of Bioengineering and Chemical Engineering. He also holds the position of the Director of Engineered Biomaterials Engineering Research Center, where his work focuses on developing advanced materials and devices to improve patient outcomes. Today, Dr. Ratner will share the latest updates on ambulatory kidney to increase vitality project, an exciting artificial kidney system being developed at the Center for Dialysis Innovation. Please join me in welcoming Dr. Ratner.
Yes, greetings. I'd like to first of all thank AAKP and George Washington University for this opportunity to tell you about a transition into the 21st century of kidney dialysis. I'm calling this talk Standing on the Shoulders of Giants, and I have great respect for the people that have made kidney dialysis possible, and I'd like to tell you a little bit about them, but mostly talk about how we're taking their amazing contributions and bringing them to the future. So it's been 80 years since the first patient in the world survived acute kidney failure. We have to thank Dr. Willem Kolff in Holland for that contribution. And also 65 years since the first chronic dialysis. And again, thanks to Dr. Belding Scribner at the University of Washington, my home institution. I'm starting with this quote. Well, it goes all the way back to Isaac Newton in 1695. If I've seen further is by standing on the shoulders of giants. Again, I will pay homage, respect to these giants throughout this talk. So prior to 1960, if your kidneys failed, this is pretty amazing. In the beginning of time, if your kidneys failed, there were no options. You died. And then based on this work started in 1940s and brought to the clinic around 1960 by these visionary giants, life could be sustained after kidney failure. Now, we can't sustain life, but what about the patient? The patient is alive, but there's a reduced quality of life. It's expensive. It's complication prone, environmentally unfriendly. And so what we're going to talk about is, again, building on the incredible work from these pioneers. Let me tell you about some of the things we're doing at the University of Washington and a spin-off company to take this to patients, Kuleana Technology, how we're transforming kidney dialysis. Yeah, so this shows Dr. Kolff. I took this photo of Dr. Kolff when he was 92, but as a young physician in 1943, he built the first dialysis machine from very crude components that he had available during World War II, washing machine parts, automobile pump, orange juice cans. You can see to the right, the first dialysis machine looks rather different from what we use today. And the woman in that little photograph at the bottom is the first human to be brought out of a uremic coma thanks to Dr. Kolf's dialysis. So that was in this era around 1940s or so. Moving to about 1960, we see these three individuals, and now we're at the University of Washington. Although Kolf's innovation was brilliant, it didn't allow chronic dialysis. It allowed just a few dialysis treatments before the patient succumbed. In the center is Dr. Belding Scribner, a nephrologist, who knew this work and said, we must be able to take this to allow the chronic dialysis of patients who will need long-term dialysis. And Scribner partnered with Wayne Quinton, a bioengineer, and Les Back, a chemical engineer, and built really the first dialysis machines as we know them today. Of course, the amazing innovation was the Quinton Scribner shunt, shown here, which actually used an amazing new material that Wayne Quinton, the bioengineer, had sort of noted, just come sort of available. It was called stuff called Teflon. Nobody had heard of Teflon before, but it made this little shunt possible. I think the first person to receive that shunt was Clyde Shields. Here he's being shown being dialyzed with some of the very early types of equipment, but his blood is being circulated in and out, and I think Clyde Shields was actually sustained, kept alive for about 15 years with this type of equipment, where prior to 1960, there would be no options for sustaining his life. So truly a miracle of medicine. That led to the growth, the development of kidney dialysis as we know it today. So we have in Seattle, the world's first artificial kidney center was opened in 1962. And now we have 63 years that have passed since these amazing pioneering efforts. So I was actually involved in this quite early. This is my PhD dissertation from 1972, looking at the interaction of urea with a new type of dialysis membrane, and certainly testify that I have had a long involvement in technology associated with kidney dialysis. And so we fast forward sort of to the 21st century. Here we have 5 million people worldwide being sustained by basically dialysis equipment. The majority of the patients use something that doesn't look all that different here. And in the first 2 decades of the 21st century, we've already spent more than $4 trillion providing dialysis to patients, an amazing number. So what are the concerns with kidney dialysis? We have it. It sustains people's lives. But there are very great access and disparities issues due to its expense and complication. Again, the economic issues are very expensive. Environmental issues, I'll mention those in a few minutes, and then technology and medicine outcomes, and particularly poor outcomes for patients and poor patient satisfaction as we do it today. The environmental impact is simply not sustainable. The amount of water we use, throw down the drain each year, 129 billion liters of water, it's enough to fill 120,000 Olympic-sized swimming pools. And water has become an expensive resource. It's also electricity consumptive, and an incredible amount of waste is produced. One example is the PVC tubing we throw in the waste each year can go to the moon and back 3.5 times. PVC is rather difficult to get rid of. If it's combusted, one of the byproducts is hydrochloric acid, not good for our environment. In thinking about how to develop a next generation of device, we started with the idea that your kidneys work 24/7. How can we expect 3-4 hour dialysis treatments a week to emulate the natural kidney? We need something that patients can use for longer periods of time. People have been thinking about portable kidney dialysis for a long time. One of our predicates, thinking about this, is the evolution of the left ventricular assist device, really the artificial heart. In 1993, the artificial heart control panels and all looked in that image on the left. The image on the center by 2007 had been reduced to a kind of a rollerboard suitcase size. And today, this gentleman has a power pack and controller for his artificial heart in a belt pack, and can lead a more relaxed life, perhaps. So that's artificial heart, but people have been thinking about the artificial kidney for a long time also, and we have patents going back to 1965 where people were envisioning how we might do this. Of course, it's fairly obvious there's nothing like this on the market after all these years today. In 2015, my colleague, Dr. Jonathan Himmelfarb, a nephrologist at the University of Washington, Jonathan is on the left, Victor Gura, an inventor, and Larry Kessler, another professor at the University of Washington who also served a good bit of time at the FDA, were testing a wearable artificial kidney for patients. It had potential, but actually failed badly in clinical trials. It simply was before its time. But it did stimulate us to think that, yes, there could be a better way, and we can use new technology to advance that. And that led Professor Himmelfarb and myself to launch a Center for Dialysis Innovation with funding from the Northwest Kidney Centers that permitted us to explore and invent a new future for kidney dialysis. We also brought in patients all along the way to guide us and work with us on developing something that patients would embrace. This is a quote from one patient: "This is ridiculous. We need to find a better way." And patients were constantly telling us, giving us advice on how to do this. So this is our leadership team. Dr. Himmelfarb and myself directed the center, but we had a bunch of remarkable people assisting us and working with us closely that were passionate about this goal to find a better way. And one of the people, very fortunate for us, was Barry Fulkerson. You can see Barry image there. Barry had worked for 35 years before he came to work with us, developing almost every dialysis machine that's on the market today. Extremely experienced with how to build and design dialysis equipment, and with the new science and technology coming from the University of Washington, Barry saw an opportunity to make a difference. Again, I mentioned we brought in a enthusiastic patient advisory board. We're very grateful for the input all these people put in. If the patients won't embrace it, they simply will not succeed, and that was part of our thinking from day one. So again, this image we generated, we call it aspirational thinking, what it might look like. Maybe there'd be a backpack that might have some components in it. And this was, again, where we decided to aim, but there were intermediate steps. We realized that wearable would be very difficult to generate in short times, but we had a better chance of generating a portable. And we viewed the portable as being a wheelaboard-sized suitcase. Patient could take their dialysis equipment on an airplane, visit their grandkids, put this in an overhead bin, be sure to have it, take it to work and dialyze. And so we wanted something that was portable and wearable, miniaturized, water efficient, more environmentally friendly, minimize the anticoagulation, robust design, cost-effective, patient-centered, and something that might restore kidney health. That was, again, our goal. One of the big issues is the necessity for water hookup and the huge waste of high-quality water. So if you look at the bottom of the slide, that's a water processing facility in a dialysis center. 400 liters of water come in, leads to about 120 liters of high-quality water. What did we want to do? We wanted to do it with 2 liters or 2 kilograms of water. And that was our vision. So what is the progress to date? I reported on this last year, and yes, there is progress. We have demonstrated we can remove 15 grams of urea a day using just 2 kilograms of water. We've made progress on portability and progress on safe, painless blood access. Let's look at some of the progress. One of the foundation technologies that we have developed that allows us to think about portability is what we call the photo-oxidation of urea. Photo means light. Oxidation means we're going to turn that urea into carbon dioxide and nitrogen, 2 inert gases that just go off into the air. So urea comes in, passes over a catalyst. It's exposed to blue LED lights, and that catalyst breaks it down to CO2 and N2. So suddenly, we no longer have to hook into a water hookup. The patient is untethered from the water connection. There's no existing similar technology that's available. This is the only one of its type for kidney dialysis. And we've patented it, and we've also published it in respected scientific journals. So the concept is out there, and the fact that it works is out there. It just shows, again, kind of a little animation. So off to the left would be the patient, and there's the dialyzer, the hollow fiber dialyzer. And in the dialysate loop, we would be circulating the urea, which is in the dialysate, the hollow fiber device takes from the patient, circulated through the pore unit, the photo-oxidation unit, which is to the right, and then clean dialysate comes back to the patient, and the urea is gone. In benchtop demonstrations, we noted that, and that's the diagram to the left, if we just take a big tank, call it a human body, we named our tank, infuse urea into the tank at the rate your body makes it. Just measure the urea in the tank, then we see the urea concentration going up, and that's shown by the red line in the graph to the left. If we turn those blue LED lights on while the urea is being infused into the tank, the urea concentration remains constant in the tank, as it would remain in a body, human body with a healthy kidney, constant. And that's what we wanted to see, is we're getting rid of the urea at the rate it's being made by the body. To the right is some diagrams showing this type of apparatus, this blue light photo-oxidation also will oxidize a number of other uremic toxins. One of the other interesting things about that blue light is it kills bacteria. Infection is a big problem in all dialysis treatments. And on top, we look at the concentration of Pseudomonas aeruginosa, a very difficult bacteria that causes serious hospital complications. And the blue light, or the photo-oxidation, is turned off. That's the blue curve. No change in the high concentration of the bacteria. But as soon as we turn on the blue light, that's the orange curve, the bacteria drop to 0. So we can keep the system sterile with just our own system that also gets rid of the urea. So where are we in the development of this device? We call it the active ambulatory kidney to increase vitality. And I'm going to show you 3 different stages. So stage 1, we could remove 14 grams of urea in 24 hours. But if you look at that apparatus we set up on a benchtop, that's pretty awkward and clumsy. We reduced that in size considerably and certainly made it neater and more efficient. That was our stage 2. And this was using blood, and we demonstrated that even from blood we could remove that 14 grams of urea in 24 hours. And here's the latest. We've taken that whole apparatus and reduced it to a size similar to a rollerboard suitcase. You can see our prototype on the right and the rollerboard suitcase on the left. And these slides also give credit to the amazing team of engineers and scientists that have done this remarkable size reduction. Thinking about such portability, patients on portable dialysis just can't go out into the world with 2 needles stuck in their arm. It's simply too dangerous. And of course, the needles are exceedingly unpleasant in any situation. In our University of Washington program, thought much about how we access the blood today. And on the left, we have the fistula, which is commonly used but has huge complications, is painful, disfiguring, and really has a all too high a failure rate in many cases. People use a vascular graft. You can see that in the center. That also has problems with clotting and such. So again, we don't get such good longevity. And then finally, there's the central venous catheter, which has the advantage of no needle sticks, but on the other hand has a high complication rate with infection or clotting. So that's where we are today. We set out to develop better vascular grafts and also improve central venous catheters. We wanted to think about better ways to blood access, and we developed a more reliable, long-lasting vascular graft, but also developed a central venous catheter approach that is safe and needle-free, and we call it the Active Connect. For our vascular graft development, realized that vascular grafts, or we believe vascular grafts, fail due to chronic inflammation. The body actually keeps on attacking them. We said, let's develop a graft that addresses inflammation. That's, I think, a unique approach to graft development. And here is the graft we came up with. It uses a unique porous structure in the graft wall that allows blood vessels from the outside to grow through the graft wall and to seed or line the lumen of this graft tube with living endothelial cells. Also, the mechanical properties of this graft were matched to the artery, so it feels like an artery in elasticity and basic feel. Dr. Elena Quiroga, who is our vascular surgeon, implanted these in sheep. On the right side, she's looking at Teflon grafts, PTFE grafts, that are widely used today for such vascular access. And what she's doing there is picking on a dense capsule that the body puts around that Teflon graft. The body literally isolates it, but it really doesn't heal in. Then on the left side, she opened our graft, or opened the surgical site where our graft was put in, and she was very surprised. Her comment was, that's strange. I know I sewed a graft in there, sutured a graft in there, but all I see now is a living, beating artery. And in fact, that graft had healed in so nicely that it looked like a part of the natural artery. And this is just some data on this very important point of endothelialization. Means these living endothelial cells that line blood vessels and make your natural blood vessel, your own blood vessels, perform just fine. As long as your endothelium is healthy, the blood vessels perform well. If we can get the endothelium on a synthetic, that should perform much better too. So you'll notice to the left should be actually 4 bars for the Teflon. The kind of greenish colored bar, which is not there for the Teflon to the left, is how much endothelium is in the very center of the graft. Teflon had none, much lower endothelium overall. Go to the right side, and the polyurethane had much, much more endothelialization. It's exactly what we want. We felt we'd made excellent progress on developing the vascular graft we wanted, but ultimately we realized we have to get rid of those needles altogether for blood access, and so that led to the development of what we call the active connection. And this will be a needleless, touchless device. It has built-in sensors and controls for safety. It integrates to the skin. It heals to the skin. It has a coating that is extremely resistant to clotting and allows the patient to use this device with, instead of heparinization required today, you could use this device maybe taking a baby aspirin a night. It resists infection. I'll show you some data on that soon, and certainly is a great enabler for home dialysis. So you see a prototype of the Skin Connect in the image on the right. This might be the controller, and again the interface with the skin and the central venous catheter that's taken to the blood is off to the right on this image. And again, this should allow it to literally heal into the skin, prevent bacterial infection, and also resist clotting. So that is the development goal in the active connection. And just to show you, we have this coating, which I think is quite unique to our program and our development that we're using. It's a chemical called carboxybetane, or polymer of carboxybetane. And we have some diagrams. The two diagrams there are actually just two different bacteria. Again, infection-causing bacteria that are problematic in hospitals and clinics. And the bacteria were labeled so they glow green. And uncoated, you can see all that green bacteria and the biofilm they produce on the materials. And when we use our polycarboxybetane coating, the CB coating, we just see dark there because there are no bacteria sticking. It has been almost perfect for inhibiting bacterial growth. And the CB is also extremely effective against preventing clotting, blood clotting. So a key challenge in all this development work, it's developed in the university. Universities don't manufacture things. Universities can't really get things through the FDA and get them to patients. And yes, we do like to publish our science, but that's simply not enough. We have to get things to patients. And to do that, we've launched a company called Kuleana Technology in Seattle. Kuleana, it's a Hawaiian word meaning responsibility and care. It's exactly how we think about it. And Kuleana Technology is licensing these developments from the University of Washington and bringing them to patients. And throughout all this program, I'll continue to emphasize, we've had the patient's voice to guide us on our efforts and ensure what we're doing makes sense for the patient. To finish up, one of our giants was Belding Scribner, and he said in 1963, he said the treatment of chronic uremia cannot fully rehabilitate if the treatment of chronic uremia cannot fully rehabilitate the patient, the treatment is inadequate. That was in 1963. I think we still have that, but I think we, the University of Washington and Kuleana Technology, will try and make Belding Scribner's dream come true, building on the shoulders of those amazing giants. Just a shout out of thanks to many students and staff here at the University of Washington who contribute to this, and of course a shout out to George Washington University and the AAKP for allowing me to communicate this message and tell you about the work we're all very excited about. Thank you.
Thank you, Dr. Ratner, for the wonderful presentation. I do have a few questions I'd like to ask you. AAKP has been honored to highlight the AKTIV system since the inception of our global summit. In summary, what the key advancements and or findings has your research team made with this device over the last 5 years?
Well, again, I think I try to highlight that in this talk. And in particular, we've taken it from a huge benchtop kludge to a rollerboard size suitcase that can do this function again. So the reduction in size to make this practical for patients has been a big development. We've had continual developments in this coating technology. Again, the patient on a dialysis machine is given a bolus of heparin to prevent clotting. We had to develop much better clot-proof systems or thrombus-proof systems. We believe we've done that. We've continued to evolve the technology around the active connect, this needleless connection. And so again, in all these areas, our team has made, I think, great advancement. And again, these things, one thing is inventing and developing, and another is implementing in a device, and that is now happening as we speak at Kuleana Technology.
What are the biggest challenges and opportunities that can be addressed over the next 5 years to support making the AKT IV system available as a treatment option?
Well, seems almost a little cynical, but again, we think about the money it would cost to do this. Again, we started with a generous gift from the Northwest Kidney Centers. We received 2 KidneyX prizes from the American Society of Nephrology and Health and Human Services. These have helped, assisted. In fact, I think we brought in about $22 million already dedicated to this. The actual commercialization of such a device, which is happening now, requires much more money. It's going to cost, and I'm throwing these numbers out, it's going to cost about another $20 million to get it to the preclinical, which means large animal tests, and then to finally bring it to the market. And this is a realistic number from somebody who's done it before, Barry Fulkerson, is maybe closer to $200 million. So these are huge sums of money. And again, maybe like to discuss scientific or technical issues. I think the biggest issue is just at this point is receiving the funding to make this all happen. But we are committed. We have begun. We have started to bring in the additional funding we need to get to the next levels. And we're excited and enthusiastic. And the active, the AKTIV, is well under development.
What gives you the most hope about the future of artificial kidney technology for people living with kidney disease?
Again, so much of this is focused on improving the quality of life and the outcomes for patients. And again, our systems liberate the patient from the water hookup. Our systems allow longer, more continuous dialysis, which more closely emulates the natural kidney. And there's much medical evidence that longer dialysis leads to better outcomes. Patient feels better and has much fewer complications. So my hopes for the future, I think are, I believe I can see a path where we are directly addressing these hopes, and I'm just excited about bringing it all to fruition and making it really happen.
Thank you for your responses again, Dr. Ratner. We appreciate you being with us and for your team's commitment to change status quo kidney care by innovating beyond brick and mortar dialysis. To close our session, I'm pleased to welcome back to this year's Global Summit, Vidmantas Sakalis. Mr. Sakalis is the CEO of Vital 3D Technologies, a company that's using cutting-edge 3D printing, 3D bioprinting, and to support breakthroughs in medical research, drug discovery, and regenerative medicine. With a background in computer engineering, Mr. Sakalis has more than 20 years of experience in ITT management and over a decade in photonics innovation. Before leading Vital 3D, he founded and grew a successful laser research startup, Femtica, which helped pave the way for many technologies being advanced today. We're excited to hear from him about the latest updates in 3D bioprinting that aim to transform kidney care. Please join me in welcoming Vidmantas Sakalis.
Hello, my name is Vidmantas Sakalis. Thank you, AAKP. Thank you, George Washington University, for the possibility to talk about 3D bioprinting and discuss vital 3D technologies and what do we do in bioprinting. As we were here last year, I was talking about the technology, about what do we do with bioprinting, and then I wanted to update you with our current developments. Just to remind you, our vision is to develop bioprinting technology to enable printing of vital human organs for transplantation. So, in fact, we are moving forward with this mission. And today I will talk about what's happening during 1 year time. Short reminder, currently we are 10 employees. We were founded 3 years ago. We managed to raise 2 million euros in pre-seed funding round for development of technology. And during the 3 years course, we have 4 patents backing our technology and 1 scientific paper published. Our team is really multidisciplinary, starting from with biotech experts down to laser people and very good software engineering. FemtoBrush. This is our leading technology, and that's the technology I was explaining to you last year. As you can see, we already have a printer, and printer is ready for GMP compliant labs to use it to bioprint the scaffolds and tissues. I will not go deeper into the technologies, just to remind you that technology is based on femtosecond laser bioprinting, working with polymers that are mixed with cells in order to print scaffolds and tissues that we are using in developing large-scale tissue bioprinting. As you can understand, the road towards the bioprinted kidney is really long. Fortunately, most of the scientists agree there are no principal obstacles in bioprinting organs for transplantation, just resources and time. We put our vision into a stepwise approach, and we are developing technologies to bioprint small, simple structures towards much more complicated structures and the organs for transplantation. So today we are working with scaffold printing, stents, and similar structures that do not contain cells. Next year we will move into the cell-laden structures, then complex tissues, vasculature, which is our main target, to be able to print vasculature for large-scale tissues, complete systems, and finally our target to reach organ printing. So first of product lines that we are developing is Cell Home 3D scaffold line. Actually, these scaffolds are small structures. It's about millimeter size. And these scaffolds are printed for drug testing experiments. Today, the drug testing is more and more relying on so-called organoids. Organoids are small representatives of specific organ. For example, kidney or liver organoids. They are like a bunch of fat cells representing the bigger organ. And researchers are using these organoids to develop and test drugs, not using the full-scale organ. The thing is that cells are usually grown into organoids accidentally. And that means that they are big or small, and when the organoids starts growing large, internal cells do not get any nutrition, so they are starting to die. And that's not very good for any experiments. Given our scaffold and cells have a structure on where they can grow, and holes in a structure just reminds something like small vasculature. So that means that nutrition is reaching every cell in an organoid. So we get much healthier organoids, much more structured, and they are much better for drug testing purposes. Currently, we are working with National Cancer Institute on development of cancer drugs using our scaffold-based organoids. Second line is VascuLife 3D stents and grafts. Usually stents are metal, and that means that from a metal it's impossible to make smaller stents for smaller vasculature. We can bioprint, and we are working on bioprinting smaller stents for that cannot be made from metal. As well, using our biodegradable material, we can print stents that degrades over time, not leaving any possibility for blood clot in a vasculature. The grafts that you can see in the middle photo are used for restoration of the vasculature, meaning that scientists grow a small vasculature by seeding the cells on this mesh-like structure of a graft, and then can replace the broken part of the vasculature during the operation. So we are developing currently the stents and grafts for vasculature regeneration. In this video, you will see the mechanical manipulations over our stents just to demonstrate the possibilities of printed structures, the structure resilience, and how they are restored to original shape after quite tough manipulations, mechanical manipulations. And finally, our product line for healing the wounds. Vital Heal is a product line that we are developing to, first of all, treat the wounds of the dogs that appears after operations when removing the tumors of the dogs. The thing is that usually tumors develop on the old dogs, and removing these tumors on the dogs leave quite deep wounds. As you can see, the wounds are really nasty, and there are not enough skin to cover the wound. So the wound heals for like 5 months, and it's really a burden for the dog and for the owner. So we are developing something like skin replacement for these kind of wounds, and we are testing them first of all in veterinary field, developing the product. Next, we will come with this product towards the human applications, and our target is to develop quite sophisticated skin models for treating diabetes wounds or very challenging burn wounds. And this is our advisory board that helps us to shape our strategy towards bioprinting organs for transplantation. We're working with academia, a lot of academia from Lithuania and Europe, as well as with industry, developing our products with a target to move towards bioprinted large-scale tissue. So thank you for listening. Thank you, AAKP, for a nice possibility to present our technology, and wishing you all the best.
Thank you, Mr. Sakalis, for that informative presentation. Before we wrap up, I'd like to ask you a few questions. My first question is the idea of a wearable, implantable, or 3D printed kidneys gives many individuals managing kidney disease a hope for future innovations that allow for more independence and the ability to pursue one's life goals and aspirations. How do you see these innovations, specifically 3D printed kidneys, providing a potential solution to the current organ shortage?
Yes, very good question. Actually, we are, with all our mission, are targeting to develop a technology to enable bioprinting of the kidneys for transplantation. And we firmly believe that one day it will be really possible, and we will solve this organ shortage question. And actually, what we are saying that we believe and we want to make the organ wait lists into survival stories.
Second question would be many in the kidney community, including patients and the doctors that care for them, worry that when new technologies are developed, there are many barriers that impede choice or access to these new therapies. How is Vital 3D working to make sure that there is a pathway to do so once the option becomes available? Is it's accessible? And furthermore, what can kidney patient organizations like AAKP and others around the world do to support those efforts?
Really, that's a challenging question because currently the regulations, for example, were not clear on the road how to recognize and to implement possibilities of the bioprinted organs to come into real usage for real patients. Currently, we have only medical devices and drugs regulation. And the bioprinted organs fall somewhere in between. At Vital 3D Technologies, we are working quite closely with different regulation institutions and academia towards the introduction and spreading the word about the possibilities of bioprinted tissue engineering. So when the first engineered tissue will be ready for transplantation, we will have much shorter regulation path towards the introduction of these organs for end users, for our patients. As I can see, and I am following the Kidney Patient Association, I see that association itself is working quite actively in helping in promoting innovational technologies. And that's the support we as technology developers need. So please continue working in that direction and give us a helping hand when needed and when the idea is ready for presentation in regulatory bodies.
And finally, as the kidney community has reached the midpoint of the decade of the kidney, where do you see this technology in the next 5 years?
Yeah, so very good question. As I showed you, the technology is progressing. It's not progressing as fast as I would like to, but the field is still really, really challenging. We are not dealing with just pure engineerical questions. We are dealing with bio things. And this kind of complicates things because it's not so easy sometimes to understand why one approach works and another approach doesn't. But I firmly believe that in 5 years, we already got some first complex tissues engineered and applied to real patient. Maybe it will be complex skin for burns treatment. Maybe it will be just printed eye parts or something like this. But we are moving into the right direction. And I hope first bioprinted organs will be on a quite close horizon.
Thank you for your responses, Mr. Sakalis. This has been an inspiring and forward-looking session, highlighting both the progress made and the promising opportunities that lie ahead throughout this decade of the kidney. On behalf of AAKP and George Washington University, I want to extend a heartfelt thank you to all of our speakers, Dr. Shuvo Roy, Dr. William Fissell, Dr. Buddy Ratner, and Vidmanta Sakalis, for joining another global summit on kidney disease innovations to share their latest updates on the groundbreaking world and bold visions for the future of kidney care.